Very good morning and warm greetings to all the participants. This is TANUVAS Global Veterinary Large Animal Sciences Webinar Series 2020. And this is being conducted from 6th to 8th November. And we have got four international speakers. And we have covered three topics, which include reproductive ultrasonography in mares and stallion by Dr. Carla Carlton, Professor Emeritus, College of Veterinary Medicine, Michigan State University, USA. That is on 6th. Yesterday we had two topics. One is by Dr. Andres Contreras, Associate Professor, College of Veterinary Medicine, Michigan State University, USA, on modulating adipose tissue function in periparturient cows. The other interesting topic was medical management of colic in horses by Dr. Elizabeth Carr, Associate Professor, Associate Chair, Large Animal Clinical Sciences, College of Veterinary Medicine, Michigan State University, USA. And today is the third day. We have got a very interesting topic on abdominal ultrasonography in horses by Dr. Orlaith Cleary. I request Dr. Mehdi to introduce the speaker.
A warm good evening to one and all. Good morning, ma'am.
Good morning.
I feel privileged to introduce today's speaker, Dr. Orlaith Cleary, MBB, Diplomate, ACVS, MRCVS, American Specialist in Equine Surgery, Large Animal Surgeon, Ontario Equine Hospital, Ontario, Canada. Dr. Orlaith Cleary graduated with a veterinary degree from University College Dublin, Ireland in June 2003. She then completed a large animal medicine and surgery internship at the University of Georgia, followed by an equine medicine and surgery internship at the Equine Medical Center of Ocala, Florida. In the summer of 2005, she lectured at the College of Veterinary Medicine, University College Dublin, and traveled to observe equine surgery in Sweden. She then worked as a resident veterinarian at Adena Spring, South in Williston, Florida, until July 2006. In July 2009, Dr. Cleary completed a 3-year residency in large animal surgery at the University of Florida in Gainesville with surgical externship in private practices in Florida, Kentucky, and New Jersey. This was followed by a clinical instructorship at University of Florida. She moved to Ontario to join the teams at Milton Equine Hospital and Allen Equine Services in July 2010. In March of 2011, Dr. Cleary received notification of passing her board certification examination from the American College of Veterinary Surgeons. From 2017, she worked during elective and emergency large animal surgery at Ontario Veterinary College, University of Guelph. She joined the Ontario Equine Hospital team in April 2019 and working as large animal surgeon till date. Dr. Cleary's special interests are in advanced imaging, MRI, CT, scintigraphy, as well as all the aspects of soft tissue and orthopedic equine surgeries. On behalf of organizing committee, I invite Dr. Cleary to deliver lecture on abdominal ultrasonography in horses. This mic is over to Dr. Cleary. Ma'am, please.
Thank you very much for the introduction. Good morning, everyone. And good morning to me and good evening to all of you. It's a pleasure to be here. It's a different platform. I'm used to speaking in person, so I'm alone in my office speaking, so I hope you can all hear me very well. So this presentation is probably just going to be over an hour. I will take it slow because there's a lot of information. I'm going to speak about abdominal ultrasound in horses. What I'll start with is talking about the equipment, talking about how to prepare your patient. Then we can talk about different sections of the abdomen and what to expect in different areas, how to look at different anatomy. And finally, I will go through quite a few cases looking at different gastrointestinal conditions, different colic conditions, how it changes the ultrasound appearance, and obviously how it correlates to surgical findings in those cases that needed to be explored with a laparotomy. So let's start. The advantages of ultrasound are that it's non-invasive, it's a real-time moving image to assess the patient. It can differentiate quite well between specific regions of the gastrointestinal tract and their location. It also differentiates very well between soft tissue and fluid. You can measure wall thickness of multiple areas of the gastrointestinal tract. And it also helps to evaluate contractions, movement of different areas, the small intestine, the large intestine, the cecum, and to see how it relates to what is considered to be within a normal range for a particular animal. And what I mean by that is when you ultrasound a foal versus an adult, you will expect to see a slight increase in motility of the gastrointestinal tract in a normal foal. The disadvantages are fairly minor. They include, if you have a lot of hair on your patient, that will be difficult. If you have a very, very obese horse or older, fatty tissued animal, it can be very difficult. If there's a lot of fecal material on the coat or a dirty coat, it can be very difficult to image them. With certain machines, it's very difficult to image deeper structures, so you could miss a deeper lesion. I find that anything beyond 20 centimeters is difficult for me to see, and so I always make sure the client and other colleagues know that if there's deeper lesions that are not accessible to me, I can't rule them out. There can be interference from gas buildup and ingesta within the large intestine, and air within the lungs can also interfere with your image. So if you want to have a clearer picture, if you have a question or an animal is clinical and you have a suspicion of a particular disease process that can be diagnosed with ultrasound, you may wish to go back and ultrasound multiple times, and I have done that in many different colic cases where I've been able to follow the progression of what is going on, and it has been very interesting. It has been very interesting to see that in different clinical cases. So for the equipment required, you should always have a clipper blade ready for yourself. Number 40 blade, and a good set of clippers. Sometimes you're going to need a backup pair of clippers so that you have enough in if you have a remote location that you're working in and you don't have, you have to be ready to deal with stuff, especially if there's an animal with a lot of hair. Alcohol, 70% works well. And in some cases, if it's a very detailed ultrasound, it does help to have ultrasound gel. But most of my cases I do with alcohol on the hair, and when I need to clip the hair, I will seek permission from the owner. Okay, so let me just start back here again. We've talked about advantages and disadvantages, which I hope you guys remember. Equipment required, a number 40 clipper blade, alcohol, gel, and a machine that can achieve a depth of 20 centimeters. And a selection of probes depending on the area being imaged. So as I said before, I've used all probes, but the ones I use mostly for abdominal ultrasound are the 3.5 megahertz or the 7.5 megahertz. I used to have access to a 5. This is the type of machine. I had used this machine for many years. These are the probes. Can you see the probes?
Yes, we can see.
Perfect. So the one on the left-hand corner up high is the 5 megahertz. This is the linear array, 7.5 megahertz. This is the rectal probe, which is 5 to 10, and then your abdominal probe, which is 3.5. So I'll stay here again. So the image format can be sector-shaped or rectangular, and you can see the probes all on the top and what we use them for. So for transcutaneous ultrasound of a deeper structure, you can use 2.5 to 5. And as I said, I don't usually see great detail beyond 20 centimeters that has good resolution. So I usually just confirm that I can see up to 20 centimeters. Transrectal ultrasound, 5 to 10 megahertz. Rectal probe, like I said, bladder stones, uterine issues, hemorrhagic ovaries, hemorrhagic follicles. I can diagnose all those, especially if they're causing colic signs, with transrectal ultrasound. And then a linear probe has been very useful to me for all types of ultrasound in babies, especially umbilical structures or ruptured bladder. So for patient preparation, you can clip hair anywhere where you need a really detailed image, or if you do a cursory ultrasound and you find something of suspicion, if you want to, you can clip the hair from that area and get a more detailed image. I find alcohol is also very, very helpful, just putting it on clipped skin. It's very, very good medium for ultrasound, but I will add gel, especially if I'm trying to diagnose a very specific lesion or looking at a specific area. So your imaging can be very extensive, or you can focus on specific areas of interest. So maybe your first ultrasound will be a full, complete ultrasound, but then your second ultrasound and your third ultrasound might be more specific, looking at areas that you have already identified as areas of interest. You may need sedation in horses, especially if they're painful or fractious or just not cooperative for handling. It'd be nice to use a clean stall or stocks with an even non-slip floor, a good handler, good communication. The best place to put the ultrasound machine, I always place it beside the shoulder. I don't place it ever near the hind legs or the rib cage. I just try to place it in a location that I can remove it from the horse as quickly as possible. The other thing to be very careful of is when you apply alcohol to the skin, some horses will not like that. So in the winter especially, because I am in Canada, it snows here every winter, I would warm the alcohol up before I would place it close to the skin of a horse, and that they would take that a lot easier. They would take that better. So let's start with talking about the stomach. Stomach I mostly image from the left side, mid to ventral. The greater curvature of the stomach is seen as a semicircular structure, and it's visualized from the rib space 8 to 13, normally on the left cranial abdomen. When I look at the stomach, I want to make sure that it's not overly distended, that it's not full of solid food material, and that I can see the wall thickness very, very well, which I will mostly measure at the time of imaging, just for my own information. And if it's thicker than normal, I will note that. What you see in the wall is a hypoechoic to an echogenic wall with a hyperechoic gas echo from the mucosal surface. And this is what I'm talking about when I'm talking about the stomach. You don't measure the hypoechoic area, you measure the area on the outside of that. And you want to have a nice curvature to the stomach. And when the horse has not eaten anything, you can see that it's empty. It's an interesting structure to image and to image across a lot of different breeds and species of horses at various stages of colic. The next structure, when I'm on the right side, it's one of the first structures that I image. It's seen from rib space 16 to 17, immediately ventral through the right kidney, can be traced orally between the right dorsal colon and the right lobe of the liver to the 11th intercostal space. And I also make sure I evaluate the duodenum at the cranial pole of the right kidney, as well as more orally. It's small and circular. I always wait for about 3 or 4 minutes and watch the peristalsis, watch its contractions. I try to identify if they're hypermotile or if it's normal, and I will always check the wall diameter and measure it. So this is examples from different horses of what the duodenum will look like at various stages of contraction. And in a lot of horses, especially if it's not involved in a colic process, it actually sometimes looks quite flat when it's not expanding. In surgery, this is what it looks like, and I really wanted to show you how to relate to the ultrasound image, because this is the liver, right dorsal colon, and this is the duodenum sitting here beside some fat. And that's why you see what you see on the image of when you're ultrasounding. That's why it looks like that. So let's talk now about the jejunum, much more reliably found. It's recognized by its small diameter, fluid contents mostly, and frequent peristaltic contractions. When you image enough horses, you will start to see when there's hypermotility of the jejunum versus hypomotility, abnormal distension, or where it's sitting completely quiet in an area of the abdomen in a horse that's got low motility, especially during a colic process. Has a tubular appearance on ultrasound, predominantly fluid contents with some echogenic feed content. Obviously, in times of colic or abdominal pain, there can be solid food material found in the jejunum, which is not necessarily normal. The location can vary in the abdomen. And like I said, it's mostly seen as collapsed or moving loops in the ventral abdomen. And these are various examples of what you'll see during an ultrasound. So here's kind of an abnormally shaped loop. These are more distended loops. They are starting to look a little bit distended, so that would be something I would keep an eye on if I was imaging that horse. And then this is in a horse with a colic issue elsewhere, which is not involving the intestines, and it's just sitting there, not involved at all, completely bunched up on top of itself. So let's now chat about the ilium. The ilium is actually not the easiest structure to see on ultrasound. It's not reliably found, but I have seen it on certain occasions, and I have known immediately that it was the ilium. It's usually located cranial and medial to the cecum. And like I said, it's not reliably imaged. Not every horse I ultrasound, I'm able to definitively say, yes, I found the ilium. Now, in certain cases, I can say that if it becomes visible to me and I can say, okay, that must be the ilium. But in other cases, I'm not quite sure, especially if the horse has a small intestinal lesion and has wall thickening, that would deceive you. So I don't ever make a call and say, oh, I see the ilium all the time. I don't. But like I said, it does have a 7-layer appearance, or it has a multi-layer appearance. So sometimes I am suspicious that that is what the structure is. The wall thickness is also increased compared to the jejunum, and it's normally 4 to 5 millimeters, as opposed to 2 to 2.5 millimeters to 3. As for the cecum, it's located in the right caudal abdomen. It has a very large diameter mostly. You can sometimes see sacculations in the wall. A lot of my cases, I'll have some highly echogenic food content, and it can be swirling, and it can also cause shadowing in the cecal wall. And the contractions of the cecum are usually orientated vertically, so up and down. The wall thickness should be less than 5 to 6 millimeters at all times. So it's sitting here on the right. It's not very well defined. So this one, a couple of these are quite full of fluid that I found on various colics. But I'd love to be able to say you can see all the walls and it looks very, very well defined, but it's not. But you can see pathology in the cecum if you are looking for it and if there's a suspicion. The large colon is a bit more reliable. You can see gas shadowing in the intercostal spaces and in each flank. The ventral colon does have a sacculated appearance and curved, and I can see variations of how the colon looks on both ventral sides, so left and right. The dorsal colon is more accessible, the right dorsal colon, and I can reliably ultrasound that on the right side, beside the liver and the kidney. And if there's a variation in the positioning of the colon, or if something's not sitting correctly in the right place, sometimes I will see a change in the positioning of the dorsal colon. The dorsal colon also is the first place I will go on the right side to check the wall thickness, especially in a horse that has a suspicion of a volvulus or a colon torsion. A lot of the times I can see a change in the wall thickness here, or I can go on the right flank or the left flank ventral and check the wall thickness of the colon there, and I can see a change in a horse that has a large colon volvulus. Not all the time, but a lot of the time. So I'm usually happy enough if the wall thickness is anywhere from 2.2 millimeters to 4 millimeters. If there is a increase in thickness above 4 millimeters, I'm just paying extra close attention to that. And I will compare different areas of the colon. So I will always check the colon thickness in various regions of the abdomen, left and right, ventral, and then the right dorsal colon, and I'll compare them. And in some cases with a colon torsion, I have found, I'll find colon wall thickness in one area, but it hasn't reached the other areas yet, usually on the left, the left ventral. So on the left side, you are, actually this is the right side here. I'm not sure why that's mislabeled, but I think it was just on the screen of the ultrasound. But on this side here is on the left, the right side of the image here. This is the spleen, and I will evaluate the colon here below the spleen. And just down here, I'm showing you how I measure the colon wall. This is 0.39 of a centimeter or 3.9 millimeters. And then on this side, this is actually the right side, but I'm checking the liver and the right dorsal colon here. Small colon, another structure that I can see sometimes very reliably, and then at other times I cannot really find it reliably. It's somewhere it's deeper in the abdomen that I can't get to. The good advantage of the small colon is that if you have a suspicion of pathology, you can always rectal the horse, and in some cases you could do a rectal ultrasound if you wanted to see things closer. The small colon would probably be more amenable to rectal ultrasound if you have a suspicion of pathology there. You can see it through a distended urinary bladder if the horse has not urinated, and on transrectal ultrasound, I've felt it with palpation, and I've been able to use a transrectal ultrasound to see it. The bladder is fairly reliably imaged in the inguinal area on both sides, especially if there's urine present in the bladder and it's filling quickly. And you can also see it with a rectal probe if you need to. The contents are usually anechoic with hyperechoic particles and hypoechoic to echoic mucus. And the contents can be seen slowly swirling on real-time ultrasound. Whenever you have a stone in the bladder that would lead to signs of colic, you will see a hyperechoic structure that you can then measure using endoscopy of the bladder, or you can sometimes measure it with bladder ultrasound through the transrectal probe. The liver can be imaged from both sides. I have reliably image the liver mostly from the right, but I always check for the liver on the left, especially when I'm looking at the stomach. It's usually imaged from the 7th to the 9th intercostal space, ventral to the lung margins, and adjacent to the spleen and the stomach wall. And it can be very difficult to find in certain horses, but it can give you a lot of information in relation to older horses, horses that have elevated liver enzymes, chronic colic. All of those things should be imaged. So I always check the liver on every horse, but in especially geriatric horses, I really want to see if there's any abnormalities in the structure of the liver that would guide me in treatment of the animal, especially if the blood work is indicating there's an issue. So it's hard to see on this image, but this is the spleen, and then the liver is only a small sliver just on top of that. Not a very good image. I've had much better images since on different machines. And this is a better image of the left. This is the liver, and then this is the spleen, and spleen has a ground glass appearance. It's pretty reliable as a structure to image. So on the right side, you can see it from the 6th to the 15th intercostal space, ventral to the lung margins, and adjacent to the right dorsal colon and the cranial duodenum. I have changed my probe if I have needed to check the hepatic parenchyma, but a lot of the time I do see a very good image on the 3.5 megahertz probe. And so this is the right side. I'm not sure why it's labeled that, but this is the right side on a different horse, showing the liver, right dorsal colon, the lungs. And if you need to use color Doppler to check the blood supply or to check something that you're suspicious of to make sure it's a blood vessel, that's quite easily done when you're looking at the hepatic parenchyma. The spleen is probably one of my favorite organs. It's also the most echogenic organ in the abdomen. It's always been very reliable to check imaging of it. I also have seen a lot of nephrosplenic entrapments with colic, so abdominal ultrasound has been a huge factor in monitoring treatment and effectiveness of any medication that we use during treatment of these conditions. The spleen is mostly on the left side of the abdomen. In certain colic conditions, such as a colon displacement, it can be pushed over to the right of midline. So once you start seeing it on the right side of the abdomen, it's either because the horse is being worked up for colic and has a displacement, or the horse's spleen is very engorged. And that can sometimes be seen in racehorses that are stressed and moving to a different location to get looked at. They can get very stressed, have a splenic contraction, and their spleen gets very large and moves over to the right of midline. It doesn't always mean that there's an issue. It extends from ventral to the lung margins at the 7th to 8th intercostal space to the paralumbar fossa, and it can also be seen from the ventral abdomen and close to the left inguinal ring. The splenic vein of the spleen is seen close to the stomach, and the mid-body of the spleen can be up to 15 centimeters across. And these are various different images of the spleen on the left side, and this shows it tapering off as the probe moves towards the inguinal region, just down on the bottom picture here. The kidneys are also very important, and as I said about the liver in geriatric horses, I will also check the kidneys very, very closely on older horses, left and right. I don't leave them out. I make sure I check them for any evidence of chronic issues. The left kidney is located deep to the spleen. It's bean-shaped. It's usually 15 to 18 centimeters long. Gas-filled bowels, such as a nephrosplenic entrapment or large colon displacement, can sometimes obscure part of the kidney from the transcutaneous approach. And that's very important when I'm managing colic cases. I can get a baseline on the left kidney and just make sure that it doesn't change while I'm treating a horse. And if it does, I have to investigate that further. I have had very good success with the 3.5 megahertz transducer to see quite good detail in the kidney. It's the least echogenic organ in the abdomen. Has an anechoic medulla and a more echoic cortex and hyperechoic fat and renal capsule. So on the left side, this is how the kidney looks. Spleen, kidney, colon. This is the kidney right here on another case on the right side of the screen. And then in another case, it's quite a bit deeper, but it's sitting right down here. And the focus point of your ultrasound should try and highlight that a little bit better. You can move your focus down if you need to see more detail. Now the right kidney is located between intercostal space 14 to 17, adjacent to the body wall. It is retroperitoneal and heart-shaped, about 13 to 15 centimeters long, so it's not as long as the left kidney. And it can be imaged very reliably, once again, with a 3.5 to 5 megahertz transducer. Sometimes gas in the duodenum can obscure visualization of the cranial pole of the right kidney, but you can usually see the rest of it. And now, as you can see, you can sometimes get varying imaging with different sizes or ages of horses, but this is your lung field, right dorsal colon, kidney is sitting right here, and the duodenum usually sits here. And then once again, this is not as good a picture. Kidney is right there. I'm not sure if this horse has a process going on with displacement, so something is pushing it back. And right here, a better image. There may be some calcification in the renal pelvis here, so we'll just have to see. Maybe that was a case I was looking at for kidney issues. Peritoneal fluid and checking for it should be part of every abdominal ultrasound examination. And when you do enough of them, it becomes very, very commonplace, just almost like it's set automatic. It just is something that you check for as you're imaging every structure in the abdomen as best as you can. It's usually seen and characterized in the ventral abdomen and in the inguinal region. It should be hypoechoic and hard to find. You should only find small little areas here and there and not a lot. But in certain cases where there's a displacement or peritonitis or changes in the abdomen that would make things abnormal, the peritoneal fluid will increase in volume. And then it needs to be characterized. So ultrasound will help with that. You can characterize it, hypoechoic, hyperechoic, mixed echogenicity, flocculent. You can look for adhesions if there's a large increase in peritoneal fluid. It's a huge advantage to be able to assess and characterize this fluid. And it does help. Also, ultrasound is extremely valuable if you have a horse that you desperately need to take a sample of peritoneal fluid and you need to characterize where the best volume of fluid is, ventrally or wherever, and you can use ultrasound guidance to tap the fluid or do an abdominal centesis. You can get a clean sample of fluid, a reliable sample, and that can be used to assess what may be going on in the abdomen. These are various cases that have increased peritoneal fluid in the abdomen. So here, right here, a lot of it will be ventral. So for a complete ultrasound, you should image from the paralumbar fossa on both sides to the 8th intercostal space. And you should pass the transducer along the full length of each intercostal space. And you have to have a system so that you don't leave anything out. So if you do enough of them, you'll get pretty fast, but you also don't leave anything out of you check everything very, very quickly, and you can get a very good overall picture of what's going on in the abdomen. And once you develop a system for that, you will actually have a very low rate of error. you will have a very good system in place to check everything. You can add, like I said before, you can add in transrectal ultrasound. You can change the megahertz of your probe so that you can see different structures. But don't ever skip a side or skip a section of a side, because I have found things in very small locations that have been surgical lesions, and they have been found in one section of the abdomen or an area where if you were not paying attention, you could miss it. So I've always learned that, to always do a complete ultrasound. If you're doing a limited ultrasound because there's a horse that's very painful or time is not on your side and you need to have the information very, very quickly, you should just, first of all, check the left paralumbar fossa for the kidney and the spleen. You can quickly check the stomach. You can check the right dorsal colon, the duodenum, the kidney, and its relationship to the duodenum, and then a quick scan along the ventral abdomen and the inguinal space on both sides to look for any cursory distended small intestine or colon wall thickening, and just briefly check the caudal lung fields while you're imaging the cranial abdomen, because you don't want to miss a diaphragmatic hernia on some of these cases, which is very rare, but it has been found. So the main thing is develop a system, do it efficiently, and you'll get a lot of information. Now I'm going to go through a lot of, so I have a lot of very interesting cases. My videos did play before, so hopefully they will play again. So let's first of all talk about strangulating small intestinal lesions. So these are a very interesting subsection of colic. I would like to say they're all the same. It's not true. I've seen so many different variations of strangulating small intestinal lesions. I have also seen quite a variation in small intestinal colic that doesn't have a strangulating lesion that can be managed medically. So the whole picture, along with your ultrasound findings, plus sequential ultrasound, can be of great benefit in management of these cases. So the clinical picture as well as ultrasound should be taken into account. And I have managed certain cases that were initially thought to be surgical medically once we found out what it was, and I was able to follow it along with ultrasound and then be able to tell when the horse was feeling much better and that the motility had improved, etc., etc. So with strangulating small intestinal lesions, there's a lot of variation in the level of distension that you're going to see on ultrasound depending on the stage of colic. So if a horse has been colicking for many hours, or if a horse has just started colicking. So it's very important to note the clinical picture. You can also have a variation in small intestinal wall thickness. So I've had cases with dead bowel that were not thickened. The wall thickness did not look any different than normal. So we have to just keep an open mind on these cases. Multiple loops can be affected as the disease progresses. You can see focal loops affected on one side of the abdomen or ventrally. When you look at the location of the bowel that looks abnormal in the abdomen, that can help in the diagnosis, whether it's cranial, ventral, or inguinal. The history is very important on these cases, along with the initial clinical picture, plus sequential ultrasounds and sequential physical examinations to kind of find out what the cause is. First of all, we're going to talk about an inguinal hernia. This happened in an 11-year-old Welsh pony stallion. This horse had an acute history of moderate, persistent colic. There was no gastric reflux obtained, and I'll tell you why in a minute. He had an enlarged right testicle, and on rectal exam, moderately distended loops of small intestine were palpated in the pelvic inlet and close to the right inguinal canal. On ultrasound, he had multiple loops of distended small intestine in the lower flanks and the inguinal region. So the reason why we didn't get any nasogastric reflux from this horse was because sometimes when you have a strangulating lesion in the most caudal aspect of the small intestine, it takes a while for reflux to build up. So in this case, most likely his ileum, which is the last part of the small intestine, would have become entrapped in the inguinal ring down beside the testicle. And it would have taken a while for reflux to build up. In fact, they're quite painful. So the signs of pain would have been more indicative of a strangulating lesion than the amount of reflux. So here on these images, you can see that the small intestine wall was measured. The diameter of the small intestine was measured. It measured, increased at 5.66 and didn't look like there was much motility. So he went to surgery. And here you have the enlarged right testicle, normal left testicle. And I always prepare to do a midline in case it's very, very difficult to get the intestines back up, or if there is dead intestine that needs to be removed. It's actually better to do it through a small midline approach so that you can decompress the intestine afterwards and make sure everything looks normal. So we removed the testicle on the right side. Let me see here. I think this is a video. Oh, no, it wasn't. Okay. So here's the testicle structure, and here is the dead very bruised and purple intestinal wall that has an ischemic lesion. So the intestine definitely lost blood supply, but I think in this case, once I got the intestine freed up, it started to look better. Took the testicle out. And very carefully looked at this area for a period of time. Just making sure it's not a video. And as you can see, the wall is thickened. It is the ileum. It's the most caudal aspect of the intestine, of the small intestine. And that's why he did not have reflux. But this area of intestine is definitely a gray area as regards whether to remove it or leave it in. But I did have a paper with Dr. David Freeman from the University of Florida where I saw a lot of colic cases, and we did have certain degrees of ischemic injury that we watched in surgery, and we would sometimes leave it in, especially if it's in a difficult location to resect, or if the resection could lead to a little bit of risk for the horse. So believe it or not, I left this in. The color improved, the motility improved. It was just heavy bruising in the wall. And this little guy did very, very well and did not need any further care, no second surgery, nothing. He did very well. And as you can see during surgery, if you give it some time, it will start to recover. And just as an aside, I have post-operative colics religiously sometimes, just to make sure that I am not missing anything when I leave a section of bowel like this back in the section, if I can find it on ultrasound, and make sure that it's doing okay. So this case worked out very well. He had a very good recovery. His diet was managed post-operatively, and I would have followed this along very carefully post-operatively to make sure that he was doing well. And ultrasound is invaluable in these types of cases. Let's move on now to, so you heard my Gastrosplenic entrapment workup. So 15-year-old pain gelding, history of acute colic, temporarily responsive to pain medication, no reflux, and distended intestine found on the ultrasound and on the rectal exam. And this is what we found in surgery. So heavily bruised small intestine in a couple of locations with a suspicion of an ischemic injury, but very bruised and hemorrhagic. Now, the next picture is a video. Can you see that? Are you able to see the video?
Yes.
Yeah, we could see the video.
Okay, perfect. So that is how the intestine looked on the video. I'm going to play it again. So good motility everywhere, but heavily bruised and hemorrhagic, but not an issue. That intestine was left in place and not removed. And it's amazing how quickly these loops of intestine can resolve and get better within a few hours in the abdomen. Now, the next picture is showing the spleen, the stomach, and the gastrosplenic space. I hope that you can see that. You can see a post-mortem picture showing the spleen and the stomach and the gastrosplenic space. This is some bowel here that is abnormal. So I just wanted to show you, and this is the liver. So hopefully you can see that picture. And I'm going to move on to the next slide, which also shows the gastrosplenic ligament. Can you guys see that? This is the greater curvature of the stomach. And then you've got your gastrosplenic ligament. There's a hole here from a post-mortem case showing that the peritoneal fat here was penetrated by a strangulating lesion of the small intestine. So that's what the anatomy looks like in post-mortem, and you can see how something might get trapped in there. So now I'm on a slide called small intestinal volvulus, and we're going to talk about a 4-year-old thoroughbred filly in training. And she became severely painful and was unresponsive to pain medication. She had a low heart rate initially, but it increased dramatically after a few hours, and her pain was lessened. Ultrasound showed distended loops of small intestine and increasing amounts of peritoneal fluid. Okay, so I'm on a slide now that's showing you ultrasound images of the right side of the abdomen showing distension of the small intestine. And this is measuring 5.7, 65, 54 millimeters. So I like small intestine. Anything over 3 to 4 centimeters in diameter, I'm paying very close attention to it. I don't mind if small intestine measures 3 to 4 to 5, as long as it's contracting normally and does not stay distended. But anything that stays distended and is more than 3 to 4 centimeters across, I'm paying close attention to that and rechecking it. So this was her ultrasound. Now, she probably, from what I remember, was not referred quickly. And when she did arrive, she was obviously intractable, and it was beyond, I don't know if surgery was even an option for her. So once I saw her and her findings, I went down. But I wanted to show you what the post-mortem findings would look like. So even if this filly had gone to surgery, the likelihood of her making a complication-free recovery would have been very slim. So sometimes a decision is made to, put these horses out of their pain and suffering, and it's not always a bad decision, especially if they have to go through some very, very aggressive treatment and it has a poor prognosis. I'm going to move on to a very common cause of strangulating small intestinal lesions, and this is a lipoma case. These are very common. I have seen a lot of these in older geriatric horses. Anything over the age of 18 or anything over the age of 15, really, with a strangulating small intestinal lesion, lipoma is one of the top on my list. But I see it in a lot of 20-year-olds and upwards. So this was a 21-year-old thoroughbred gelding. He was inappetent, and then he was depressed, dehydrated, showed colic signs. They're not always terribly painful. They're just moping and depressed. Rectal examination revealed distended loops of small intestine in the pelvic inlet and in the ventral abdomen. Ultrasound confirmed these findings. 2 large lipomas were found involving the distal jejunum and the proximal ileum. And a jejunocecostomy was performed on this case. This is showing you an example of what different levels of strangulation of the small intestine can look like, even in the same case. So this one had thickening of the wall here, increased peritoneal fluid. And then a very common thing to see on ultrasound in strangulating small intestinal lesions is sedimentation of the food material in the lumen of the small intestine, which is quite interesting to see, but this is ventral, obviously. And then this is very significant. So if you see something like that, you've got to be watching carefully. Another example of some sedimentation down here with starting to look like the wall is getting a bit thickened. So this case, you can see the two lipomas, quite a tight band. There's a blanched area on the intestine right where the lipoma would have been sitting. And this would have been removed. A video here showing the lipomas attached, and the intestine is absolutely non-viable. This intestine is without a question non-viable and has a terminal ischemic lesion, so would not ever, it's pretty obvious that this would need to be resected out of the horse immediately. Once I think I'm showing here that I've done the resection, and I'm checking movement of fluid from the jejunum into the cecum. So I did jejunocecostomy. Cecum is right here, side to side. All the abnormal tissue has been removed. And at the end of the resection and anastomosis, just want to make sure that there's good transition of fluid through the anastomosis into the cecum. So that went well. But that's what this horse needed to remove and get the tissues back to healthy, functional tissue. Now I'm going to move on to a case, Intussusception, in her routine or diet, otherwise, aside from the fact that she had had surgery previously. Acute onset moderate colic. On rectal examination, I palpated a firm tubular structure medial to the cecum and running on midline. On ultrasound, I found a thickened small intestinal wall with telescoping of another portion of intestine. So this has a bullseye appearance on ultrasound. This was very interesting. So this is very characteristic of an intussusception right here. If you look very carefully at the picture on the right-hand side of the screen, just on the bottom, you can actually see the outer wall on the bottom, and then the inner walls of the part of the intestine that has telescoped in to the outer part. This is an example of how we measure different walls. Needless to say, I recommended immediate surgery on this horse, and I ended up reducing the intussusception, and I ended up with just some bruising, which was very nice. I'm not sure if I have a video that's going to play automatically here. I don't think so, which is good, because then I don't want it to stop my slide. So I was able to reduce it and get a good picture, some bruising of the blood vessels right here, but otherwise this filly did very well, and I'll tell you why she did very well. She was brought in very, very quickly after she had her little bout of colic. She was brought in right away for evaluation, and so once the abnormal ultrasound finding was seen, we were able to go directly to surgery, and no resection or anastomosis was needed. It was a very successful case. She left about 3 days later and everything went well. So this was showing good motility of the area, and hopefully I can move on to the next slide now. Just let me know if this video, can you see a very dark area? Can you see that now?
Yeah, we are able to see.
Okay, So this is showing an intussusception in a different location of the intestine that was quite serious. I think it might have been an ileocecal. Anyway, this shows the types of parasites, Anoplocephala perfoliata, that would have led to this type of intussusception. On rectal examination in this filly, she palpated like she had a large colon displacement, but there was distended small intestine that was seen on ultrasound. And she did have an entrapment in the mesodiverticular band medial to the cecum, and this was not visible on ultrasound. So this was her mesodiverticular band right here, and there was an entrapment of the small intestine into this band. These are showing her ultrasound findings. This is a very interesting case right here, where you have normal intestine that also got involved after a piece of intestine that was non-viable was also involved here as well. Epiploic foramen entrapment is the next case. These are very interesting cases. There's some variation between them, but they're very rewarding when you can get them into surgery very quickly. The ultrasound pattern is very interesting here. Like I always see distended small intestine very close to the right side near the liver, especially if there's going to be a thickened wall. It will be close to the liver on the right side. So when I see a pattern like that, where I have a thickened wall, strangulation sitting cranially, I'm thinking right away gastrosplenic or epiploic foramen entrapment, so that I can narrow my diagnosis. But you can't rule out lipoma in an older horse in that area. This horse came in very, very quickly. Distended small intestine was seen on the right side close to the liver. And one segment was found to have a markedly thickened wall, about 7 millimeters across, compared to the other loops. And I recommended surgery right away based on my findings. So some sedimentation here, thickening of the wall, distension of the loops. And I was able to relieve the ilium and part of the jejunum from the epiploic foramen. There was some bruising, some surface hemorrhage, but otherwise this horse made a full recovery. This is another epiploic foramen entrapment in an 11-year-old thoroughbred mare that had a history of cribbing. I find that cribbing sometimes is associated with this, sometimes not, so it's hard. I always ask about cribbing, whether or not it's related, but I don't find a huge correlation. Didn't get any gastric reflux, no small intestinal loops palpated. Ultrasound revealed distended loops of small intestine in the lower cranial right flank and the cranial abdomen beside the liver. So these were her ultrasound images. This image right here would immediately give me a warning signs, and I would probably take the horse to surgery just based on that image alone. That is a very telling image. These are also very supportive. So I think I remember getting her to surgery very quickly. So let's see, I think I was able to get this out very, very quickly. And so there was actually minimal bruising of her intestine after I relieved it. And then you can see I'm demonstrating. Can you see me demonstrating now? My hand is here, my surgical hand. I will check the motility of the small intestine by doing a quick snap test to see, very, very non-atraumatic, but just flick the surface of the small intestine to see if it responds to that gesture, and to see what the motility looks like. Let me know if the slides are not moving, but I just moved on to another image showing a blanched area after an epiploic foramen entrapment was relieved, and this would have recovered within a couple of hours. Resection is performed on this case. Can you see the resection picture?
Yes.
Perfect. So this is showing a mid small intestinal resection, jejunal, end-to-end, jejuno, anastomosis. And this is a fatty tissue gathered up here. But whenever I need to resect it, they actually do pretty well with these types of resections. This is a good case, diaphragmatic hernia on a 6-year-old warm blood mare that was used for jumping. She did not have any clinical signs noted previously, except for reduced performance. The owners were unaware of the presence of a diaphragmatic hernia, and she one day colicked after competition and had respiratory distress. A large hernia was seen in the left dorsal aspect. So on ultrasound, a lot of intestinal structures were seen right up in the cranial abdomen associated with the lungs. So that does not look normal. That shows you that there's intestine sitting in the thoracic cavity. Now, this was an ultrasound video. Hopefully it's not taking up as much room, but I'm going to move on to the next ultrasound video and show you what it looks like. Can you guys see that?
Yes.
Okay. This is also a good one because it's got the diaphragmatic ligament, and you can see the heart beating and intestinal structures around the heart. The heart seems to be under pressure. Now, this horse, I don't think this horse made it. Obviously, this is a post-mortem image. You can see the lungs, the intestine up behind the lungs, the diaphragm right here. So the best picture to show you is the next picture here. This is the whole diaphragm. And you can see the tear that occurred in the diaphragm that led to this hernia taking place. So obviously some type of trauma was sustained. But what's interesting about this case is I think this is the tear, and then this area would have been a pre-existing hernia because of the mature edges of the wall of the hernia. This would have been a mature hernia that maybe she was living with, but then something traumatic happened and tear propagated. And that's how the hernia became more severe. This is an example of a mesenteric rent, an 11-year-old thoroughbred mare, 5 days post-foaling. Colic signs were minimally responsive to pain medication. She was very painful. She had focal distension of the small intestine with twisting of the bowel, palpated on the right side of the abdomen, medial to the cecum on the rectal exam. And distended small intestine was seen with thickening of the intestinal wall on the right side running from the lower paralumbar fossa to the liver. These images show thickening and distension of the small intestine. And so this horse was taken, well, actually, I don't think surgery was an option, but I always try to do a post-mortem when surgery is not an option. I always offer it. I don't charge for it because I really want to correlate my ultrasound findings with the pathology that is found. And so this shows you, obviously, a strangulating small intestinal lesion. And then when everything is opened up and spread out, there was a rent in the mesentery here. So unfortunately, that horse did not make it. This was a sand impaction in a 6-year-old quarter horse mare. She had been inappetent for 2 to 3 days. She was initially responsive to flunixin, but then she became more painful. On rectal palpation, a large firm impaction was palpated in the pelvic flexure in the large colon, and ultrasound showed a grainy impaction in the large colon, confirmed to be the pelvic flexure. This is what it looked like, this grainy sand type abnormal. It doesn't look like normal feed material seen in the pelvic flexure. So I took her to surgery and flushed out a lot of sand. And thankfully, I flushed out the colon very, very well. And she made a full recovery, but we did take time in surgery to get as much sand out of everything as possible. That was a lot. This next case is a post-mortem of a horse that actually presented with a very large impaction in the colon, and it had sand in it also. So you can see the sand here intermixed with the feed material. So that was a different horse, but I just wanted to show you what it looks like on post-mortem. Large colon volvulus. This is a very common colic in post-foaling mares, almost pre-foaling mares. I've seen a lot of these in my career. It can be very dangerous to work around them, so they don't always respond to medication. Sometimes I've had to put them under general anesthesia right away to take them in because they match everything, and I found a colon torsion. The quicker they go to surgery, the better to get resolved, but they can progress quite rapidly. I don't always get to perform a rectal examination. I do get to sometimes check the thickness of the colon wall on ultrasound, but I don't always get to perform a full clinical examination. Sometimes I just have to take them right to surgery. But the ultrasound has been helpful because it's safe, and I could quickly check for thickening of the colon wall. And so these are some of the cases I've seen where this one was 1.38 centimeters, this one was 1.03, and this one was very thick. I think this would have been probably 2 centimeters or 1.8 centimeters. This is almost a centimeter here, very thickened. If the horse is painful and I find that on the wall in the ultrasound, it's pretty much an immediate surgery for me. I take them right to surgery. This is to show you what different colon volvuluses will look like. In this case, the horse had venous return was reduced, but it still had a very good arterial supply to the colon, and that's why the thickening was there, because the venous return was not great. But this case had complete strangulation of the arterial and venous blood supply, and led to this. The wall is not that thick, and the mucosa dies very, very quickly. So the mucosa becomes non-viable very quickly in these types of cases. Just an example of the color, how it looks when you open the abdomen, and the type of weight, very, very heavy, some of these colons. And then we have to be very careful with these cases. If you can see the picture here on the upper left, this case has so much edema in the wall that if you're manipulating the colon, you have to be very careful not to penetrate the colon with your fingers. It can happen very easily. Thankfully, it only happened to me on one case in my career. That horse had a very tight 520-degree volvulus, and I pretty much just touched the colon in the abdomen and it tore. So it was pretty much a very advanced case that was probably not going to make it, but the damage to the colon was so severe that it just broke under very light digital pressure. So this is a large colon resection process that I did, and this is the end result of the anastomosis. I just want to show you what a lot of colon volvuli or twists will occur at the base of the colon beside the cecum, but sometimes you'll have a volvulus occur at the sternal diaphragmatic flexure, and that's what it looks like. So in a 2-year-old gelding, this was an abdominal mass, underwent surgery for a large colon displacement and an impaction 1 month previously. Pelvic flexure enterotomy was performed and subsequently stapled with a TA90. The horse was colicky with fevers for the following month. And the horse ended up having an abscess on the right side, beside the liver, from the intercostal space 15 cranially. And this is kind of what I saw on the ultrasound. Abnormal, this looks like an abscess. We'll move along to the next picture. Because this horse ended up having a couple of surgeries, but unfortunately, the abscess was located at the diaphragmatic reflection onto the inside of the body wall. So when the abscess was drained, it unfortunately could only be drained at that location, but it contaminated the thoracic cavity. And it happened as a result of some type of adhesion and leak from the previous pelvic flexure enterotomy that was closed with a TA90 stapler. So I've never used staples to close an enterotomy. I always use, the only time I ever use a stapler is to do a jejunocecostomy, and then I oversew the staples with a normal suture. So I think the staples have been exposed, this leaked, caused an abscess. And then the abscess was drained on the table, but what ended up happening was the horse got peritonitis and also got pleuropneumonia from abscess contamination of the thoracic cavity. So I think it's always very important to know that the diaphragm comes back quite a ways here. And you have to be very careful if you're doing percutaneous drainage of any type of a mass in the abdomen to make sure that you know your landmarks and you know where the lungs are, you know where the intercostal spaces are, and that you stay away from the diaphragmatic reflection, because even at this level, that abscess was able to contaminate the thoracic cavity. And on post-mortem, you can see the diaphragmatic reflection here. And when the abscess was drained, it was done through the diaphragmatic reflection. And that's why the lungs, unfortunately, became involved. It was a terrible condition in this horse. The horse, I haven't actually seen anything like it since. I did have a case last week that was a very severe abscess post-castration, but it was nowhere near the lung field. So this was a very interesting case. This was a young saddlebred gelding. He had chronic weight loss, poor body coat and body condition. He was not performing well. He had intermittent colic, treated with Banamine several times, but no consistent improvements. And a rectal palpation revealed a local mass just cranial to the pelvic inlet. Transcutaneous and rectal ultrasound confirmed the presence of an abnormal mass and thickened small intestine in the area. So I don't think this is a very good image, sorry. That's the thickening of the small intestine. So you can see now what I found in surgery. I took him right to surgery. He had an abscess and adhesions he had. So that was cultured. And I hope that it goes on to the next picture for me. Did it do a transition? Because this horse had a perforation of its small intestine that led to an abscess forming, and he walled it off. And then we took out a whole section with a resection and anastomosis, and he ended up doing really, really well. Can you see the hole in the small intestine on the upper right of the screen?
Yes. Yes.
Yes?
Yes, ma'am.
So that was a ulcer that perforated and led to the abscess and the adhesions that you saw up there. So he did very well, put weight on, did very well after surgery. That was him doing well after surgery. He was very, very skinny when he came into us. Just wanted to show you another case where I found a wire foreign body right here. And that case did well too. That was a resection. And I just want to show you what that looked like. Very interesting. Very, not a lot of evidence on the outside of the intestine, but this horse, the wire had perforated the serosa and was leading to a leak. This is also a horse that had a resection and anastomosis, and it was just showing how we're evaluating everything after surgery. Now, I'm moving on to a new slide. I'm just giving it a little bit of time. We're on the last couple of cases, so I hope you can see the slide. This is going to talk about a case that had an enterolith in a 4-year-old. Is it still on? Okay, let me go back out. Now, you should have a slide that talks about enterolithiasis. 4-year-old pained mare. History of chronic colic responsive to administration of Banamine. And she also had moderate gastric ulceration. Abdominal radiograph showed a circular radio opacity in the cranioventral abdomen, which was characteristic of an enterolith. And an exploratory laparotomy was performed to identify the radio opacity. So right here, I'm going to circle this. This was what was considered to be significant on the radiograph. Sometimes you can see these on ultrasound too. And then this is the enterolith that was removed when the colon incision was made. And that is the enterolith, and you can see the nidus. I always x-ray these after they're removed because then you can see the nidus that led to the mineralization of this stone. Certain areas of North America are pretty prevalent, they're pretty common. Texas, California. I had some in Florida, but not a lot. This is another case which had it was a smaller horse, and you can see the radio opacities quite well on this case. And this is the 2 stones that have been removed. Now, this case is talking about gastric rupture in a 6-year-old American show pony. Had a short history of moderate colic and high heart rate. No reflux, but when the tube was passed, the pony became even more distressed. So that's a very important clinical sign. If you pass a tube and the horse gets very, very painful or very stressed, then it's something to think about and ask yourself if the stomach might be involved. So the ultrasound showed increased hyperechoic flocculent peritoneal fluid in the ventral flank region. So this is pretty telling here. That's quite suspicious, this flocculent peritoneal fluid here in the right flank. That would have been very suspicious for me, along with increased peritoneal fluid elsewhere. And then when the horse went to surgery, it was an insurance case. So the horse had to go to surgery for it to be confirmed that it was a rupture of the stomach for insurance purposes. Otherwise, I would have just done a post-mortem. So you can see the fecal material, or the ingesta of the stomach leaking out when you make the incision. It was a very large tear, and obviously leading to gross contamination of the entire viscera in the abdomen. Another example of a gastric rupture on the post-mortem floor, greater curvature of the stomach, and an old rupture, obviously there's not much hemorrhage along this must have occurred post-mortem, and that was maybe pre-mortem. It may have propagated when the horse was euthanized. Cecal rupture in a 6-year-old standard-bred gelding. Horse had a history of mild to moderate colic and reduced fecal production for 3 days. And 24 hours before admission, he became very distended and uncomfortable. Rectal examination revealed a distended viscus on the right side. And on presentation, the horse was tachycardic. He had injected mucous membranes, muscle fasciculations, which is very characteristic of a rupture if they start to shake and look shocky. Nothing significant was palpated on the rectal exam. Ultrasound displayed copious amounts of hyperechoic peritoneal fluid, and the abdominocentesis confirmed the rupture. This is just showing what a normal cecum looks like in surgery that has distension, very distended. So sorry, this is not a ruptured cecum yet, but this cecum would have ruptured if we had continued to manage medically. So this case would have had a cecal enterotomy performed, and the fecal material was emptied out to try and relieve this. Just another case of rupture of a viscera, more likely the cecum, and how it looks in post-mortem, and the immense peritonitis that it causes very rapidly. And another peritonitis case where you have more long-standing changes. This is buildup of fibrin around the gut wall, and it was in a foal. Just want to quickly show you what a broad ligament hematoma looks like. They can become very, very painful and shocky postpartum. History of a high heart rate, pale mucous membranes. They may or may not have a hemoperitoneum. So some broad ligaments can burst into the abdomen, some will not. So sometimes if there's back pressure on the bleed, they can stop and the horse can improve. This is showing you one I found on ultrasound. It's not very well defined, but in real time, you can see it more reliably. It's hard to show it on a still view. And post-mortem, this is showing a hematoma right here in the broad ligament. That was very severe. That horse had to be euthanized. And that's basically it. I tried to give you guys as much examples as possible. But I will say that ultrasound for me has been a huge tool in my arsenal for my clinical cases. And it has been invaluable to me, especially with abdominal cases, colics, older horses with abdominal issues. I have found things that I wouldn't have expected to find. And it has been a very rewarding part of working with horses, is to have been able to train myself and develop a pretty good clinical ACVS at ultrasound. It has helped me a lot with management of medical and surgical cases. So that is the conclusion of my presentation. I will escape from it and I will just go in and put on my video. And if anyone has any questions, please don't hesitate to ask.
Yeah, if there is some videos, we'll just finish watching the videos, then we'll go for question. Any video is pending?
No.
Okay. So, Dr. Cleary, that was a good informative lectures. We are very much satisfied with the number of case studies. So that's very good. With the illustrative, with each cases, we really enjoyed. And the questions, 316 questions are there raised by the participants. But we are restricting to some 10 questions because most of the questions are answered in your lecture. So I'll go by one. For ultrasound, a case study of stomach rupture you have been discussing. Can we take like this absence of visualization of stomach through ultrasound Can it be taken as a stomach rupture? Always, or should we suspect?
When you're talking about increased peritoneal fluid, and you're talking about when I'm passing the nasogastric tube. In a lot of cases of rupture, I have seen a change in the demeanor of the animal when the tube goes into the stomach. But I have also seen it where they have a very severe gastric impaction or a large colon volvulus and the stomach is under a lot of pressure. When the tube gets passed, they can react quite violently in some cases when the tube enters the cardia of the stomach. So it's part of your overall picture, along with ultrasound and with your clinical picture. It's all very important to note that. I've always paid very close attention to the behavior of the animal also with different diagnostics. And I've done a lot of colics over the last few years. I mean, I used to live, breathe, and eat colics. They were just in my life every day. So I was able to correlate. I mean, definitely if there's a stomach issue, the horse will react. And it doesn't always have to be a rupture, but it could be a horse that's got a very severe impaction or stomach pain, ulcers. It all has to be, we have to keep an open mind.
Thank you. During the discussion, Dr. Cleary, you were telling about the flap test. Can you elaborate on that?
What was that again? Talking about the
intestine, during the surgery, you did some test. Flip test.
Oh, yes.
Yeah.
So I'll show you my hand. So if I want to check the intestine, I just go boop. Just a little flick.
Okay.
And then what happens is normal intestine will react very quickly and will move. You can see a surface change. It'll react right away to feel or touch or to that little flick. But intestine that has poor motility or has a very severe ischemic injury will not move at all. However, I have waited in some surgeries anywhere from 15 minutes to 40 minutes. So what I do is I always do a full exploratory. So if I have a lesion, I've identified it, I have resolved it, but I'm not sure what the intestine is doing or if I need to do a resection, I will put everything back in the abdomen and I will go and I will look at all of my other structures and I will make sure that everything else is okay. And then I will pull out that section of intestine that I was concerned about and I will reevaluate it a number of minutes later and then see what we need to do.
That's interesting. Regarding the features of lipoma, it causes entrapment of the intestine. Did you see the lipoma? Can we see lipoma through ultrasound? Any features of it?
I have seen it. I would say less than 5 times I have been able to identify a lipoma itself on ultrasound. But I did see a couple. One of them was seen on a mare that had intermittent chronic colic, but not bad. And I found a large fatty structure in her abdomen and it had not strangulated yet. I took her to surgery and I removed the lipoma and it weighed about 1.5 pounds. And that is why the mare was colicky. She was feeling the weight of that lipoma dragging her intestine from one side of the abdomen to the other. And that's why she was uncomfortable from time to time. But she did very well once that lipoma was removed. But I do remember seeing that one very well on ultrasound. But I cannot, I can only tell clients or horse owners of my suspicions based on age and the presenting signs of the horse. And yes, a lot of the times if I say it, I believe it's a lipoma, I am correct, but that's only because I use that diagnosis specifically in older horses or a specific age group, and also relating to the clinical signs.
Thank you. Dr. Clary, regarding the during discussion on epiploic foramen entrapment, you are telling that by seeing the ultrasound features of this slide, I'll directly go for surgery. So would you please re-emphasize those characteristics?
So if I see specifically a thickened loop of small intestinal wall on the right side between the kidney or between the right dorsal colon and the liver, and it's specifically in that area, and I have thickened wall, I have to think of a cranial abdominal strangulating lesion, and that could either be a lipoma if it's an older horse, but a lot of the time, most of my epiploic foramen entrapments have been in horses from the age of 6 to 15. And so I would be telling the owner, I would always ask about the cribbing history, even though I know that there are papers that say there's no correlation between cribbing and epiploic foramen entrapment. I know that that has been stated. However, I always ask, and I have seen a couple of cribbing horses that have had epiploic foramen entrapments a couple of times. They were repetitive. So I always ask about that. But yeah, that's a very reliable, but then again, I keep an open mind. I try to always try and make a diagnosis before I go to surgery, because I think it makes me a better clinician if I can think that way and try and narrow it down. And that is why I always do a post-mortem on an abdominal case if the client allows, and don't charge for it, because I want to be able to see after the fact. If I end up euthanizing a horse, I want to see the pathology so that I can learn more from the case, and so the death of the animal is not in waste, so that at least we can learn from what we saw and try and help other cases.
Thank you, thank you. The bullseye is pathognomonic for intussusception, is it? Yeah, bullseye.
Yes, very characteristic.
Very characteristics for intussusception. Can you tell in how many percentage we can pick it up in those horses with intussusception? Can you pick it up this bullseye in all the cases?
You can pick up the bullseye in most cases, and also in babies' foals. It's very easy to see because of their body walls are thinner and they don't have as much fat. So it's very easy to see in those cases. I would say if you know what you're looking for, so if you combine your rectal exam, so some cases will be a cecocolic intussusception, some cases will be a ileocecocolic intussusception, some cases will be a jejunal intussusception, or a jejuno-ileal. There's a few different types, but if you try and correlate your clinical picture with the horse rectal exam, the side of which is affected. I have ultrasounded ileocecal intussusceptions. I have seen them. They are not as easy to define as they're not as easy to define. So you just have to be very cognizant of what you're looking for on ultrasound. And so with the ileocecals, I have seen the cecal wall, increased fluid, and then a thickened structure, tubular structure sitting in the cecum. And that's how I had a suspicion. But I can't always call it on the ultrasound. I can only speak that I have a suspicion. And then usually the pain level of the horse is enough to go to surgery.
Okay. But for the enterolith, we have missed the ultrasound features in your lecture. Do we get, can you describe the US features of enterolith, or we mostly depend on radiograph?
With an enterolith, you're pretty much just going to see a gas shadow, or a shadow. You're not going to see beyond it. It's just going to be a wall. Yeah. So I would always radiograph a horse, especially if they're smaller, if I had a suspicion, especially if the horse came from a region where enteroliths were common.
Okay. We would like to get through your mouth once again the pathognomonic features of strangulation. So, the specific features of strangulation in ultrasound.
On ultrasound, so like I said, there is a variation depending on the stage of the colic and how quickly the horse was referred. If the horse is at an early stage of strangulation, sometimes you won't see anything on ultrasound. You might see a decrease in motility of the small intestine. It might just sit there. Maybe it'll be mildly distended with a non-thickened wall. But I always keep that in mind. And that's in those cases, I will come back in 1 hour or in 2 hours and I will redo the ultrasound, especially if I don't have a decision. And then there will be changes. There will be a difference. There will be a progression of signs. So then you might start to see that the intestine is more distended, more loops are visible, nothing's happening. The wall is starting to get thicker. And then you might say maybe the horse is comfortable, maybe the horse is not comfortable, but maybe it's still a gray area. You come back again in 1 hour and check again. And then sometimes you have enough evidence to say, yes, this is it, go to surgery.
You were telling about something or stands on the ventral part while dorsal part is with fluid. What is that?
Oh, I was just showing, because my image was upside down, all your fluid will always collect ventrally, so it's closest to the probe. When you put the probe on the abdominal wall, your fluid, if you have increased peritoneal fluid, it'll always be closest to the probe.
In one case studies, you are telling about a string. Does it cause a linear foreign body-like syndrome, which we get in dogs? Intussusception case?
Oh, I think that was a wire. It was a small wire that the horse had ingested, and it entered the wall and created a foreign body reaction in the wall of the intestine, and then leaked a little bit, enough to create thickening and a reaction on the serosal surface. So fibrin would build up, and the horse, started to have colic because there was thickening and the function of that section of intestine was compromised.
Thank you, Dr. Cleary, for your very patience in answering the questions posted by our participants. Thank you once again. Now, may I request our respected and beloved Director of Clinics, who is already on the line, for his concluding remarks for this webinar. Dr. S. Balasubramanian, Director of Clinics of TANUVAS. Sir, over to you, sir.
Thank you, Dr. Vijay Kumar. Am I audible?
Yes, sir. Yes, sir.
Okay. Good morning, Dr. Orlaith.
Good morning.
Before I go into the concluding remarks of this Global Veterinary Animal Sciences Webinar Series 2020, because once I saw your name and the place from where you're, so it reminds me of the days when I was in Ontario in 1997 and 98. I did my postdoc in the University of Guelph under Dr. Stanley Lebo, who's no more. He passed away in 2015. And I'm quite familiar with Dr. Keith Bettridge. You must be aware of him. He's a professor emeritus in Ontario Veterinary College. And another person, his name is Dr. Rudy Welshi, equine specialist.
I think I know Rudy.
He came from University of Zurich, and he did his postdoc along with me.
Very nice.
This is way back in 97, 98. So I had a very nice time, both professionally and personally in University of Guelph. So let me go on to the concluding remarks. Your lecture on abdominal ultrasonography in horses was a very exhaustive lecture, very informative, illustrative, and interesting. So I think you started with the very basic things, like from advantages and disadvantages of an ultrasonography, the equipment requirements, what are the equipment requirements, what are the different types of probes to be used, and you covered the anatomy of the part which is going to be subjected to ultrasonography, like starting from stomach, duodenum, the jejunum, and the interesting points which here and there you pointed out. I think it would have been very useful for all the clinicians who are working in equines, especially like when you said on ileum that it is difficult to image ultrasonography. It is very difficult to image. Likewise, the cecum, the way the contractions take place, which is more oriented vertically, and the other aspects like large colon, then liver, spleen, kidney, and peritoneal fluid. And coming on to the type of ultrasonography to be performed, you just summarized that when you're going to do a complete ultrasound, then you need to do on both sides of the paralumbar fossa. And when you're going for a limited ultrasound, quickly you go through all the structures. And the most interesting part of your lecture was that of the case examples. So the case examples were with the surgical procedures here and there with the videos, the postmortem changes or ultrasonographic changes, which you observed in different types of cases. For example, in strangulating small intestinal lesions, inguinal hernia, gastrosplenic entrapment, and intussusception, then epiploic foramen entrapment, diaphragmatic hernia, intestinal perforation, and likewise these structures or the cases which you have dealt. I think this would definitely be very beneficial, useful to the practitioners who have encountered or who are likely to encounter such type of cases will be much prepared by going through all these things, procedures, and take all precautions. And you said it is a very valuable, a versatile tool, a diagnostic tool in diagnosing most of the conditions in the abdominal cavity of the equines. So once again, I would like to thank you for having readily accepted and having given delivered an excellent lecture. Thank you, Dr. Orlaith.
Thank you very much, and it was a pleasure to speak with all of you, and I hope my lecture was helpful.
Definitely.
Thank you, sir. Thank you for your concluding remarks. May I request Dr. Sijesh Ayman for proposing vote of thanks.
A warm good evening and good morning, honorable present here. It's my privilege to propose a vote of thanks on this occasion. On behalf of organizing committee, first of all, I would like to thank this opportunity to place on record our hearty thanks to our Honorable Vice Chancellor, Professor C. Balachandran sir, for the perfect logistic support and permission for the successful conduct of this webinar. I also extend my heartfelt thanks to our Director of Clinics, Professor S. Balasubramanian sir, for providing encouragement, guidance, and support. We are really enlightened with your knowledge and presence. I also extend my heartfelt thanks to today's speaker, Dr. Orlaith Cleary, for accepting our invitation and delivering the lecture. Already our director of clinic, sir, explained elaborately. And once again, starting from the advantage, disadvantage, then probes, then the interesting thing, what I thought was that case examples, that means different surgical procedures like gastrosplenic entrapment, then lipoma, then sand colic, then perforations. All these things were interesting. And the thing is, what I thought was everything in one hands. That means ultrasound, then surgeries, then the photos clarity was very good, and the videos was also very good. So enjoy definitely the information gathered by us is lot. Definitely will be useful for us and those who attend this webinar. Thank you, ma'am. And you grace a lot of information and you share it elaborately. Thank you, ma'am. Next,
Thank you.
I would like, thank you. Next, I extend my thanks to Mr. Karunanidhi, Vice President Alambic, and Dr. Santosh Shinde Alambic for the technical support for the successful conduct of this webinar. I also extend my thanks to the Dean, MBC, Basis Deans, TANUVAS, for extending the facilities for the conduct of this webinar. I also express my thanks to Dean and faculties of all the colleges of TANUVAS for the support for the conduct of this webinar. I also thankful to the students and veterinary practitioners of India and abroad for the participation of this webinar. Without the participant, we can't able to achieve this. I also thank Dr. Arun Prasad sir and Dr. Tirunakaru sir and Dr. Vimal sir for providing technical support for this webinar. Once again, I thankful those I missed, those who directly and indirectly helped this webinar. Once again, I thankful to chairman and co-chairman for the providing permission for this vote of thanksgiving. Thank you.
Thank you, Dr. Simon. So once again, we thank our Director of Clinics and Dr. Orlaith Cleary for this participation and beautiful delivery of the lecture. Thank you.